Hello everyone and welcome again to our 3D Systems webinar. My name is Tal Arziz and I'm the product manager for the Angiomentor line of products. And today I'm going to moderate this exciting webinar on transseptal puncture and pulmonary vein mapping. So our webinar will be divided into three parts today. First one, Dr. DePonti from Italy will discuss transseptal puncture techniques, catheterization and PV mapping. Then we will demo this procedure using our angiomentor simulator, and we will have time at the end of the session for questions from the audience. If there will be any questions that will not be answered during the webinar, we will reply them in an email at the end of the session. Just a few tips on how to participate and work with during the webinar. So on your right-hand side of the screen, you will see a box where you can type and send your question to the panelists during the webinar. And from time to time, we will ask you poll questions. So please answer by clicking the relevant answer on your screen and submitting it. Just a few words on our company, 3D Systems. So 3D Systems is a world leader for 3D printing, software and printing services. The healthcare division is proudly offering unique solutions for surgical planning, personalized medicine, and virtual reality simulation. Our angiomentor simulator is the most advanced simulator in the field of endovascular, providing unique training solutions for more than 26 different clinical procedures, and today over 200 cases used for training of multiple disciplines. Just a little bit about our product offering for EPs. First is our basic skills module. This is a unique training module that allows you to practice essential skills in safe, non-anatomical, as well as medical environments, as you can see here in the video I just showed you. The CRM module was designed to develop competence in EP intervention as lead placement and includes simulation of selected measurements and complications. We also have the Transseptal Puncture module, which allows practice of what we will see and learn today, and includes different fossa valley stiffness, locations, ultrasound guidance, and complications. And the last one is AF ablation, a great module for the practice of cryoablation or RF ablation for pulmonary vein isolation, and includes realistic EP signals and life-threatening complications. In our module, we also have the ultrasound imaging that is part of our product offering with high quality and real-time ICE and TU. So before we start, we would like to ask a few poll questions to better know the audience. First, we will ask what is your specialty. So you'll see, I'll open the poll and you'll see just in front of you, please enter and submit the poll. Okay, so from what I'm seeing here, most of you are electrophysiologists, which is good. Second question is in regards to your experience with transseptal puncture procedure. So again, I'm going to open the poll. Please answer and submit your answer. So closing this poll, and it looks like most of you had no experience at all with transseptal puncture cases, although we have a few people that are very experienced here, which is nice. Question number 3 will be if you're using ice as part of the transseptal puncture cases in your center. So we'll close this poll, and it looks like ultrasound is not used at all. Nice. And last question. Last question will be, what is your experience with virtual reality simulation? So I'm going to open the poll now, and please provide your answer. So most of you answered that you've never tried it. So we have an audience composed of electrophysiologists with not a lot of experience in either virtual reality simulation or transseptal puncture cases, which usually don't use ultrasound in their facility. So I think now is the time to present to you our speaker today. So Dr. Roberto DePonti, with over the last 25 years, his research and clinical practice has focused on interventional EP and catheter ablation of cardiac arrhythmias. Three-dimensional mapping and simulation for EP training are also in his field of interest. He has published papers on these topics in peer-reviewed international journals, and he is a fellow of the Arrythmia Society and a member of the Italian and European Societies of Arrhythmology. Dr. DePonti, thank you for joining us. I'm going to allow you to control the presentation from now.
Okay. Thank you, Tal, for the invitation and for the opportunity to speak in this webinar. I think, I hope you are hearing me properly, the right way. Is it like that? Are you hearing me?
Okay. Yeah, it sounds very well.
I'm online. Thank you again for coming to this webinar. And again, I take the control of the presentation. And okay, this was the editorial I wrote some years ago just to tell that transseptal catheterization is a matter of both technology and training, meaning that yes, we have to have the best technology in the world to perform transseptal catheterization, but we have to have also the best training in the world to perform a transseptal catheterization in a safe, successful, and sometimes also quickly way to support the procedure. My presentation in the next 20 minutes, my presentation will be finalized to demonstrate that training is essential for this kind of procedure. And just to tell you that there will be another webinar tomorrow held by our friends Joseph Kautner and Jose Luis Merino. And then, of course, this webinar is not in competition with them. This will be held by the European Arrythmia Association, and that will be free for ERA members. But then our will be focused on the need for training in these cases. So let me do some preliminary consideration, and then we will go into the core of my presentation. Then we will see the role of simulation in this kind of training. First consideration, this was a survey that we undertook more than 10 years ago in Italy, and we collected more than 5,500 procedures of transseptal catheterization. You see that almost 80% of those procedures were performed for atrial fibrillation ablation. And that study was undertaken just to understand if the widespread of this procedure resulted in a disaster in terms of success rate and complication. You see here we had a very nice successful rate, which is close to 100%, and you see also that the complications were well below 1%, which is good. So at that time, in a small community like the Italian EP community, we adopted a model of training which is now obsolete. That model of training was done in a way that people with less experience went to the centers with more experience just to learn the transseptal procedure, and then those who had more experience went to the minor center to support the procedure at the beginning. Again, this is an old model which was successful at that time, but we have to have a future perspective. So, second preliminary consideration, this was our first publication on transseptal puncture, and we are doing more or less the same way. This is fluoroscopy based, using the coronary sinus catheter and this bundle catheter, and then what we do is what you will see in the next slide. Third preliminary consideration is about the anatomy. You know that the area in which we can puncture the septum and be sure that we are going safely into the left atrium is the area of the fossa valley, which is a relatively small area of what is perceived as the interatrial septum. You see here an anatomical image. By the way, these images are taken by the Yen Ho and Sabine Ernst book, Anatomy for Electrophysiology, published in 2012 by Cardiotext, and I advise you to, if you don't have already, to buy this book. Then you see here the orientation of the atrial septum and the angle between the orientation of the interatrial septum and the plane of the back of the patient is more or less 45% degree. Sometimes is smaller, and so we have to orient a little bit more posterior the needle. If we go too much anterior, there is the aortic root. If we go too much posterior, we have the posterior wall of the right or the left atrium. Then again, you see the anatomical perspective. We keep the coronary sinus when we base our procedure only on fluoroscopy. Then our coronary sinus catheter is placed here, and it identifies the os of the coronary sinus. And then the east bundle catheter identifies the non-coronary cusp, which is nicely shown here. The fossa vallis is here, just posterior and a little bit higher in this area of view, a little bit higher than the position of the east bundle catheter. Then let's go into the core of my presentation very quickly. I will show you the procedure workflow, some issues concerning the procedure, how to manage difficult cases, and then we will talk very briefly about complications and training. Then there are many ways, more than 1,000 ways to perform transseptal puncture, and they are all right. Every way is good, provided that there is a predefined workflow of action that should be done carefully during the procedure. For the purpose of teaching in our center transseptal catheterization, we subdivided the procedure in 6 steps. You see here the steps, actually there are 7, but look here, the first is the baseline catheter positioning, as I told you before, and then of course over the wire, we position the transseptal assembly in the superior vena cava. Then please understand the underlying philosophy of this step-by-step way to proceed. We have 2 crucial steps here identified by an asterisk, but for each step, since it is crucial for the safety and the whole procedure, we verify in the subsequent step that the previous step has been accomplished the proper way. And I'm going to show you that very quickly in the next slide. You see here, with the needle inside the dilator, with the needle indicator oriented at 45 degrees, we withdraw up until we see a small jump that you will see in a few seconds here. Then again, this is a crucial step, so we verify here in the aerial view that the position is posterior to the east bundle catheter, as I told you before, is just a little bit higher here and is just more posterior than the os of the coronary sinus, which is good. Then, if we have the verification has gone well, we go ahead and we puncture, we protrude the needle, then we apply a gentle pressure to the whole assembly, and we perforate the fossa valis very gently. And then we check here with dye injection. Probably the resolution of the slide won't allow you to, you see here there is a small cloud which quickly dissolves and go down to the ventricle, which means that we are in the, the distal part of the assembly is in the right place in the left atrium. And then we finalize the procedure by advancing the transseptal sheath into the left atrium over the dilator. Then there are procedural issues that we will see very quickly in the next slide. Sometimes we need to curve a little bit more the needle. We usually use a BK0, and then we apply manually shape in the distal and even in the more proximal part of the needle according to the type of the atrium. If we have enlarged right and left atrium, we applied a more marked curve to the distal part of the needle. Then the second issue is that we have to keep the stylet inside the needle lumen when we advance the needle inside the body of the, inside the dilator, when both the dilator and the sheath are inside the body of the patient. Then, if you don't do that, the distal tip of the needle scratches the inner lumen of the dilator and produces this plastic particle, which is called the skiving phenomenon. If this particle, as you see here, they detach from the dilator, then can embolize and produce systemic embolism, which is something that we don't want to happen. So you see here the needle indicator is oriented at 4.5, between 5 and 4. But then, as I told you before, sometimes the angle between the septum, the interatrial septum, and the back of the patient is narrower. So we have to rotate a little bit more the needle indication, and you can go even to 7 or 8 o'clock if the fossa valis is very much posterior. Then another important challenge is represented by the tortuosity of the femoral, iliac, and vein and inferior vena cava. In these cases, as you see here, although we insert very carefully the needle. The needle is markedly deformed. You see here there are 3 curves and there are deformation. These are my fingers. You see here is touching the table and here there is a big space. It means that the needle has been markedly deformed by this kind of vein tortuosity, which again represents a challenge to perform a transseptal, to reach the right position of the fossa ovalis and then to perform a successful and safe transseptal catheterization. Then, interestingly enough, we have the issue of double puncture of the septum. In many centers, we perform double transseptal puncture just to bring the lasso catheter and the ablation and mapping catheter in the left atrium. In these cases, it might be that the fossa ovalis is very small, so the fossa ovalis is completely obliterated by the first transseptal puncture once the first transseptal sheath is inside the fossa ovalis. In these cases, if you attempt with the second transseptal sheath to perform the second transseptal puncture, the second transseptal sheath can be diverted, and then we have trouble in reaching the right place, so it can be diverted more posteriorly or more anteriorly. So what we do in these cases is very simple. We do the first transseptal puncture, then we put a long guide wire in the left superior pulmonary vein. We withdraw in the right atrium the first transseptal puncture, then we insert a second catheter in a second transseptal sheath. We advance the catheter across the first puncture in the left atrium, then we advance the second transseptal sheath over the second catheter, and then again we advance the first transseptal sheath over the guide wire so that we can bring safely a second catheter in the lasso catheter and the ablation catheter in the left atrium. So now let's consider in a few minutes tips and tricks in difficult cases. What to do when the fossa ovalis is not localized, is not unexpected, because you see that there are many anatomical variants of the position and of the width of the fossa ovalis. In these cases, this will be very easy to perform a transseptal puncture, whereas in this case, it might be difficult to perform the transseptal puncture. And you know also that the thickness of the fossa ovalis is quite different. There could be a more muscular and very thin fossa ovalis. In some cases, it is very fibrotic and very thick. So, in these cases, of course, you see here, there are, in some cases, the posterior displacement of the fossa ovalis is well expected when you have anatomical variants of the torso, of the abdomen, some minor congenital cardiovascular diseases, or some other acquired diseases. Then in these cases, we can use ultrasound in the form of standard or real-time 3D transesophageal echo or intracardiac echo, and I prefer definitely the intracardiac echo. Then you see here one example. The aortic root is here, the right atrium is here, the left atrium is here, left superior and left inferior pulmonary vein. You see that very nicely the tenting of the fossa ovalis by the distal part of the assembly is clearly seen, and then we can perforate safely when we see something like that. So if you look at the consensus document, you see that usually the use of intracardiac echo to support the entire procedure is recommended but not mandatory, and we have to admit that we have conflicting feelings about the routine use of intracardiac echo. We can say that at least in Europe, this is used on a routine basis in no more than 20% of the procedure, according to the ERA surveys. And then my position is that we don't use that on a routine basis because, as I told you before, we perform the transseptal puncture, based on fluoroscopy with the help of catheter placement in the coronary sinus and east bundle catheter every time. But of course, we have ready the intracardiac echo in cases we have difficulties in identify the position of the fossa ovalis. Then, what to do when we have a resistant fossa ovalis? You see here in the old days, I have just stained by dye the fossa ovalis, and we can confirm that the needle is inside the fossa ovalis. I pushed a little bit more, but the fossa ovalis displaces, but nothing happened. The septum is not perforated with the fossa ovalis. So what we can do in these cases, we have two options. We can use the needle with the RF, which has been demonstrated in prior cases that can be used successfully in this retrospective analysis, or at least, as you see here in a prospective randomized study, we demonstrated that, the authors demonstrated that this kind of RF needle shorter the time to transseptal left atrial access with less failure in achieving transseptal left atrial access. So what we use on a regular basis, you see here is the transseptal guide wire, which can be inserted over the needle. It is very sharp in the distal part, although it is very, very thin. And as soon as you advance this guide wire over the needle, it resumes the J shape, so it's completely automatic in the left atrium. You see here one case. Here I'm pushing the needle, LAO projection, east bundle catheter, coronary sinus catheter. I'm pushing, but nothing happens. So you will see that the guide wire is coming out and will be positioned in the left superior pulmonary vein. Then in these cases, the procedure, now you see the guide wire, I can push a little bit more and the procedure can be safely accomplished just because the needle is protected by the guide wire, which has been positioned in the left superior pulmonary vein. Then what happens if we have a closure device? Usually there is no problem with the atrial septal defect as being closed by the surgeon, but then there could be problem when we have an occluder. So in these cases, our ability to reach the left atrium very much depends on the size of the occluder and on the position of the occluder. If the occluder is relatively small and has been positioned in the to close a patent foramen ovale, which is a little bit higher, we still have the fossa available to be punctured, and then we can accomplish simply the procedure. When the closure device obliterates the fossa ovalis, that is another problem, and then it could be done, but then it's a quite difficult procedure. So the last couple of minutes, just to say the complication and what is required in terms of training to safely accomplish the transseptal puncture. Complication rate, again, this is our survey. Complication rate is very low, well below 1%. Mortality is not zero, but is very, very low, provided that we have the appropriate training to face the procedure. Because you see that we may have life-threatening. That is not zero again, and we may encounter life-threatening complications. So, of course, we reach the left atrium just to map the pulmonary vein, and we will see what will happen afterwards with the simulation of mapping of the pulmonary vein. And the pulmonary vein, of course, are mapped just to tell us about the endpoint of our procedure, which is complete isolation of the pulmonary veins. Then training is important. First slide here is just to tell you that we were able to, together with Hugh Perkins and Alan Cheng, to have the proof of concept that simulation training is better than conventional training for transseptal, to learn transseptal catheterization. In this study, we randomized fellows to conventional training and simulation training, and after training, they performed 3 consecutive procedures, and we scored those procedures in real patients for the first time. And you see here the score in the first, second, and third procedure of people who train on the simulator was significantly better. The score and the quality of the performance was significantly better as compared to those who train conventionally. And the reason why is very clear. They avoided a lot of recurrent error as compared to those who train conventionally. Then this is another proof of a concept we use in 2 centers together with Richard Schilling and Waka Sula in London. We use the Anciamento electrophysiology simulator. And again, as you will see afterwards, this simulator has 5 modules in which you can practice in maneuvering catheters, both diagnostic and steerable catheter inside the heart, 3-dimensional cast of the heart, of fluoroscopy image of the heart. And then we were able to demonstrate that the score obtained in these modules correlates very much with the experience of the operator, which means that these modules are very much realistic. And then we define a minimum score which is required in our center to get to the real patient, to the real procedure for those who are novice in electrophysiology. Then I will end the presentation back to Tal, to Israel. Are you there?
Yeah, I'm here. Thank you very much, Dr. DePonti. It was very interesting. I definitely learned a lot today. So now I think I would like to present a video demonstrating the procedure that we just talked about on our angiomental simulator, of course. And it will be great if you can guide us through the procedure and explain it to the audience, exactly what we're looking at.
Okay.
So just a second while
Okay, this is a very nice way to present a simulation room. Here the simulation, the lab, the real lab is reproduced in the simulation. But then you see here the exercise, which is very much appreciated by fellows, of mapping in a LAO on the left side and RAO projection the pulmonary veins, left pulmonary vein and right pulmonary vein, by using the sheath and the circular mapping catheter. You see now that the circular mapping catheter is positioned inside the left atrium, again on the left LAO, on the right RAO. You see here the gain which is proposed. You have to enter the left superior pulmonary vein, position stably on the ball, which is the target side. As soon as you are able to stay there firmly, you can get at least 40 points for the first pulmonary vein reached. Then you see here, this is another fellow try to engage the left inferior pulmonary vein. At the end, by rotating and pushing a little bit, the circular mapping catheter is able to reach the target side in the pulmonary vein, and he gets another 40 points. The same will work for the right superior pulmonary vein. To complete, you see here the sheath and the lasso catheter are clockwise rotated, and then again the exercise is finished with the right inferior pulmonary vein. Maybe we can switch to the next movie. The same very elegant suite for simulation, and again, it's not easy to reproduce completely a virtual lab. Sometimes just the okay. Here is just to say that we have on the right side the virtual reality screen, and on the left side the computer screen. You see here that the operator on the lower part of the right side, on the left side of the screen, you see that the ice is introduced. Again, these are high fidelity hybrid simulation, which means that you have an haptic device, which is basically the virtual patient, and then you have the screen of the computer, a dedicated computer, which tells you what happens in the haptic device, provided that the proximal part of every tool is realistic, is real, while the distal part of the tool is simulated. You see here we have reached the nice view in the center of the screen, the nice view of the septum. The right atrium is in the superior part, the left atrium is in the inferior part. We have put the guide wire in the superior vena cava, and over the wire we have advanced nicely the transseptal assembly in the superior vena cava, dilator, and transseptal sheath. Then the lumen is flushed and the needle is carefully advanced up until the distal part of the needle reaches the distal part of the dilator without protruding the needle. You see here that the operator is taught how to measure the distance, which guarantees you the safety of not protruding the needle in the superior vena cava. Then again, the system is calibrated so that we can start the maneuver of withdrawing the transseptal assembly needle. You see here better, needle inside the dilator, dilator itself, and sheath. Everything is moved down with the needle orientation at 4 or 5 o'clock. You see here in the eyes picture that very slowly here the center of the fossa of eyes is engaged. So we might check this position also by injecting a little bit of dye by through the lumen of the needle. You will see here that something should be appear. Okay, you see here a nice painting. Also here, you see also the pressure here in the lower part of the left side of the screen. This is the arterial pressure. You should see sooner or later when we enter the left atrium the pressure. Okay, here it is entered, the pressure is not available. Anyway, we have a nice picture in the eyes image that the needle has entered the left atrium. You will see a dye injection here, if I remember correctly, and then the dilator is advanced, as you see here also in the eyes image. Again, you will see here that the pressure reappeared. So you see that the dilator is inside the left atrium, and very soon the sheath will be advanced over the dilator. Again, here you see both on the right side the fluoro image, and on the left side the eyes image and the pressure recordings. Here some dye has been injected through the lumen of the transseptal sheath, and this confirms that we are in the left atrium. The first transseptal sheath has been accomplished. the system gives you, of course, the option to perform double transseptal puncture to learn also this maneuver.
So thank you again, Roberto DePonti, for your guiding this and explaining to us exactly what we've seen. I think it's time to answer some questions from the audience. So we got a few questions during the webinar. First one is, how important is it to learn how to perform transseptal puncture safely for EP or interventional cardiology?
It's very important. It's very important we already discussed for electrophysiologists, but also for interventional cardiologists. We learned more than 25 years ago how to do transseptal puncture by interventional cardiology, because at that time they did a lot of procedure in the left atrium. But then this kind of concept has been lost over the years. Actually, it's quite important because nowadays we have the option of putting an occluder device in the left atrial appendage, or to have some operation on the mitral valve in terms of balloon valvuloplasty or mitral clip. In these cases, they are very sick patients. In these cases, performing a successful, safe, and also quick transseptal puncture is the way to have a successful procedure in these cases. Training is very important to maximize success and to minimize safety and to minimize complication also for them.
Interesting. So second question is, how is transseptal training conducted around the world?
This is conducted in 1,000 different ways. There are still centers that are focused on the conventional way to do that. The conventional way is very simple. You look your tutor and then you try to replicate the procedure. This is what we did up until we had the simulator available. Then as I showed you, we performed the randomized study and we learned a lot by that kind of study. We learned that, for example, simulation training is by far shorter than conventional training, because in that paper we published that simulator training lasted on average 4 days, while simulation training conventionally lasted roughly 1 month. And this is very important in terms of time. The second thing, we learned that, for example, fellows, they locked them up in the simulation room for 2 days, and then they did like 30, 40, 50, on average, if I remember correctly, they were 50 procedures in 2 days. So they become very familiar with the procedure, with all the steps of the procedure, and this they can replicate very nicely the same thing when they go in the real patient. So again, the training is very variable. What our choice now is for transseptal catheterization and for many other procedures, our option is simulator. Although, you know, the development, all the simulator step and improvement, we saw very nice picture, but again, improving to a more complex model of simulation is demanding for everybody. But then, you know, for novice people, for sure, simulator training is the best way to learn how to do that.
Do you know any guidelines for transseptal training?
Let's say in 2008, some guidelines were published, and in those guidelines they stated there was no mention at that time of any kind of simulation training. they stated that 10 transseptal catheterization were enough to learn how to do the transseptal puncture. But I showed you how many variables we have in the procedure. In some cases, when you have a large and very thin fossa ovalis, it's very easy to perform even the double transseptal puncture. But then after a few cases, you can encounter more difficult cases. In this condition, 10 are not enough, and probably more than 10 are required. So the 2015 guidelines for training, which are published in Heart Rhythm Journal, the first name is Doug Zipes, they say in a line that simulator is an emerging platform to assist training. Of course, we have provided some evidence that the simulation training is better than conventional training. We have to undertake some more studies, some more larger studies to demonstrate definitely that simulator training is superior to conventional training. This is a perspective for the future, but again, the fact that the currently released guidelines mention that there is a simulator training is already something for us.
Yep, so very encouraging. I think
Yes.
at this point, unless we have another question from the audience, we will conclude the webinar. So once again, thank you very much, Dr. DePonti, for your great talk today. And thank you all for joining us today. So just to let you know, the webinar was recorded and it will be available online in our website. And
thank you.
At the end of the webinar, you will see a short survey that will, and we will really appreciate if you can participate in it. So thank you again. And goodbye, everyone. Have a nice day.
Thank you and goodbye. Thank you.